I think this panel is going to give you kind of the proof of the pudding. You know, is this going to work? Is it of value? Is it actually going to be doable? And what are some of the possible kinds of challenges and how we're going to be dealing with? So this is the panel that's actually, I think, as Louise saying, those communities that are actually coming together to do this. Just very quickly, I'll just introduce the panel, and then we're going to actually make some opening remarks. So we have on the end there, Per Joergensen, who is here from the hospital system in Denmark. We've got Gareth Baynam, who I think was mentioned previously a little bit, but really delighted to have him here from Australia and wide awake, I think, at this time. I'm not sure why. We also have Dr. Carmencita Padilla, who's here from the Philippines and one of the most I think, engaged physicians in the Southeast Asian region. We've got next to her Mr. Salman Saif, who is going to be providing somewhat of a patient perspective, but also a real innovative way in which we're connecting. And then at the very end, we've got Lisa Sarfaty, who many of you will know has been a long-term member of RDI, and we're delighted to have her here on the panel. And then by remote, we're going to have Professor Johnny Mahlangu, who's going to be talking to us about the experiences in South Africa. So in order to get right into it, I think, we're going to hear from the perspectives of the different panelists. I'm going to actually start with, with you, Salman. I think you're up first, right? And what we'd like to know is, given what has been presented here, and obviously you've heard it before, from your perspective, right? How is this clinical network? Is having a clinical network going to be helpful to you in terms of what you're advancing in terms of persons living with rare diseases, and maybe kind of be able to connect that for us? What are you doing, and how does this fit in?
Oh, sure. Thank you very much. So I would say, like three things, right? So first, when we talked about developing countries, right? So for most, it's already a challenge to do the basic things or access to basic things like education or health and others, right? And then second is that if you have a rare disease, then just, like complexify the things by 100 times. Third is that the public health care is not that effective, so people needs to go to private care, which is very expensive. That ultimately means that you are left behind, and in that way, for a disease which could be very well manageable or treatable, right? But then also for those who could afford to pay, for them also, like how it works, that the expertise are limited to different centers. So that means still quite some difficulties to travel and access and all that. So what I'm trying to say is that if there is a way to bring those expertise closer, which can help in terms of timely diagnose, and also making or helping with a treatment plan, that can already be a significant value, right? And the good thing is that it's possible to do that, right? Because we, as CureforU, have done a successful proof of concept, starting from Pakistan and then extended to Afghanistan with some European countries to, like make this kind of a pool who can help to bring those kind of expertise where it's required, right? With the guiding principles, and I was very happy to see the slides, which is like equitable representation, joint ownership, so it has to be working together, not one person telling the others to do. And third is that it has to be fit for purpose, which also means that there has to be a learning from both sides as well. So I was very happy to hear what Matt was presenting and others were saying that, because it's all going into the direction with our successful proof of concept. So to your question, it's very much required and it's very much helpful.
I think Matt said it because people like you have been telling him that. That was not something Matt invented. So thank you very much for your examples, for the work you've been doing on the ground. And so obviously kudos to Matt and Louise for being able to pick that up and incorporate it. So great on you. And I think you're going to hear a bit more. So Carmencita Padilla, I'm going to turn it over to you. And maybe you can tell us a little bit, as a healthcare professional, certainly in a very challenging environment already in terms of the Philippines. She's not going to have the opportunity to tell us all the things she's been doing there over the last number of years and the huge advances they've made. But I'm going to ask you a different question, and that is, you've been making huge advances as a clinician, in terms of trying to advance rare diseases and certainly having a huge amount of progress. is this actually going to make more work for you and for other clinicians in the region who are already, I think, working flat out in terms of being able to address not only the needs of your population, but also being able to spread the work that you're doing?
Thank you. Let me start by saying that I come from a country with 7,000 islands. 20 or 30 years ago, 30 to 40 years ago, they told me it was impossible to implement newborn screening. And I can tell you that 25 years now, we're in 7,400 hospitals in 7,000 islands with a coverage of more than 90%. So I think it's possible, whatever we're doing, but how did we do it? So Matt loves this story, so I'm going to share with you. I said I used a bottoms up technique, and I shared a dessert in the Philippines. So you'll have to come to the Philippines to taste it. But it's a rice cake that's cooked with fire on top and fire at the bottom. And I said, you have action on top with the leaders, with the policymakers and the funders, and then you've got action at the bottom, working with the clinicians and the patients. So the challenge now for me is that how am I going to do this with 2 million babies a year? We have an infrastructure. So I think the lesson is for everybody in the community is to start with the infrastructure. I have the infrastructure of newborn screening right now. We've expanded to 29 diseases with a lot of rare diseases. And the infrastructure of the clinicians on the ground is important. There are only 15 geneticists, so definitely this networking is going to be very important for me. I think we're ready, but we need a lot of help. And a push from the global community will even make it easier for us. I work with government, but it's not enough. So if I have this community of clinicians, then it's going to work. So nothing is impossible. I think it is very possible.
You are the living proof of nothing is impossible. And at some point, you need to have Dr. Padilla tell you some of her experiences of actually doing newborn screening with 7,000 islands, especially in the middle of a typhoon. So if you want to hear about spectacular nothing is impossible. And now for another view in terms of nothing's impossible, because it is quite incredible. I'm going to ask Per Joergensen to talk about your experience in working with the European reference networks and certainly your hospital, with the commitment of your hospital. But given what you're already doing, why do you feel that you need to be part of this global network? What can you lend to it? And maybe what can you get back from it?
I come from a little country with only a population of 6 million people and a public healthcare sector. The National Board of Health has located 2 different centers for rare diseases in Denmark, and one of the centers is located in the hospital where I work. And it gives us a certain responsibility. We've been very pleased by the ERNs, or European Reference Networks, because we believe that that's the important part. They're good for the patients. They're good for our patients because even though we are used to handle rare patients, we of course also have problems with the very rare patients. And it's very helpful to have access to experts all over Denmark in that regard. And we're also pleased to be able sometimes to help the other European countries when they have very rare patients. I think it's very important for the hospital to be part of this because it gives us an access to an international network of European experts at least, and it gives us opportunities to be on our toes and also to have new research possibilities. That's important for us also in relation to rare diseases. And this formal network, which the European reference networks are, have one big advantage from my point of view, and that is that they have created a system, a virtual system, where we're able to discuss specific patients across borders within the EU. And that's very, very helpful. And I think it is actually very important. In relation to the global network, I think that our hospital might be a sand grain, and the ERNs or the ERN system might be a kind of hub in a national global network. And I think it's true what is said, to pool knowledge is very, very important, and we're very eager to participate. Thank you.
Thank you very much. And what Perry did not say is that out of the 24 European reference networks, their hospital hosts 22 of those. So that's an incredible tour de force. So we're really proud. And now I'm going to turn it over to Gareth, who's going to talk to us about the experiences from down under. And really, I think one of the things, we wanted you to comment on is this operational description. I know you were part of that working group, and how does that work for you there, but also a little bit about how you're actually going about now in terms of the core of centers of excellence, because you're already doing some of that in Australia.
Thanks, Dane. I think it was possibly Matt that said this is not a nice to have, this is a must have. And we already have. And what I mean we already have is we already have so many people and their families living with rare diseases. We already have an enormous health and social burden and responsibility. We know, at least in developing countries, that rare diseases are the single biggest health system cost. So we already have this great challenge. And that's why it's so critical that we build on the things that we already have in terms of our existing approaches and work with a global network to learn together. A critical step on a patient's journey is getting a diagnosis. So a diagnosis is the portal to best medical care. A critical step on a systems journey is defining what you need to address. Until you define and operationalize what you need to address, you cannot address the challenge. And so I think that's the fundamental reason why this operational definition is so critical for local action and for coordinated global action. In terms of opportunities to learn and lessons to learn from, I think what we're seeing, and certainly what we've experienced locally, is that solutions from more isolated, potentially less resourced countries or regions, and I think even within high-income countries like our own, we can certainly see the great disparities between urban care and rural and remote care. We can see the great disparities between non-Indigenous care and Indigenous care. But amongst those disparities, also we see that necessity is the mother of invention. And we see that those solutions that have been generated and honed in Indigenous populations, or generated and honed in low and middle income settings, or generated and honed in remote settings, are robust and they're generalizable. And so in fact, another advantage, a key advantage of this global network is the learnings that we get in better resourced high-income countries, the solutions we actually get from the global community and how they address challenges in their own contexts.
Thank you very, very much, Gareth. Now we're going to turn over to Lisa. Lisa is here as from the National Organization for Rare Disorders in the USA. And I think NORD, as all of us know, is probably the oldest maybe patient association there is. NORD was instrumental in getting the Orphan Drug Act, without which none of us would actually be here. So that's really important, because without that Orphan Drug Act from NORD, Eurordis would not have been able to do what it's doing. So we're all here sort of on the coattails of what NORD has been able to do. But now we're coming back to NORD is actually creating centers of excellence, and actually somewhat late in the game compared to what we're hearing from the Europeans and even from the Australians. So tell us why you felt it was important for NORD to take on this task, and what you're doing and what maybe the vision is.
Hi, everyone. Actually, Hong Kong might have been first. I thought I heard that from someone, that they were founded before NORD. So I'll have to verify that. But so glad to be here with everybody. Taiwan was first. So we don't hold that title. However, back in 2021, NORD launched the Rare Disease Centers of Excellence program in the US. And hearing from fellow panelists, it really felt like an uphill battle that we didn't know that we were ready to climb, to be honest. It's no small feat, but like everyone said here, it seemed there was no choice but to do it. We needed to do it. So patients in the US face astronomical healthcare costs, in addition to lack of access due to a variety of factors having to do with the healthcare system and just the fact that these diseases are rare and expertise isn't always in the US or even available nearby. And so what we were finding is that there were multiple clinical networks and research networks and diagnostic networks, but they were siloed and they weren't working together. And patients were still falling through the cracks. And what we really felt we needed in the US was to give patients a medical home, a place that they could go to, geographically located near them, where regardless of the disease that they had the ability to see someone that understood fundamentally what it meant to have a rare disease. So they may not be an expert in your rare disease, but they understand the journey of rare disease. They understand where to go to for information on rare disease. They're connected to other networked clinical professionals and researchers in rare disease. So for me, being part of this conversation, it's taking our vision 100 times further, right? This idea of building out a clinical expert network in the US and now taking that and extrapolating it globally and ensuring that patients, again, who have diseases that they could be one of 10 people in the US, but maybe they're one of 100 people worldwide. How do we make sure that they get connected to the expertise and the resources that they need? So, NORD took that on as a patient advocacy organization, and I'm glad we did. I was hesitant, I'll be honest, because it seemed more than we could handle. But today we have over 31 centers participating, and we'll probably have nearly 45 by the end of next year. There's over 200 volunteers from across clinical genetics, geneticists, genetic counselors, other specialists working together to really define what this needs to be. So as mentioned, we're really doing it from a grassroots perspective of bringing the clinical community together with the patient community to really define how do we make sure that this supports the clinical community who's in desperate need of resources and support, but then also the patient community so that their needs really don't get lost sometimes in these bigger picture conversations. Because for individual patients, it counts from the minute they show up at that door. What is their experience showing up to that site? How are they triaged? How are they supported? How long does it take to get another appointment? All of these factors are taken into consideration to ensure a really holistic experience and a baseline for what a rare disease patient can expect. So we're in the beginning, but really looking forward to working with this community to help us as we pilot and grow this program, ensuring that it can support the global community as well as patients in the US.
That's brilliant. Thank you very much. And I think what you're already hearing, I think some of the questions and challenges that come forth, how can you have sort of a concept of a network of centers of excellence when you've got so much variation across countries and across regions? And what you're hearing is that kind of what, Carmencita said, you build it from the bottom up and you build it from the top down to fit kind of what the environment is. And I think we're seeing, as Rebecca said to us earlier today, we're seeing lots of different models in terms of, both prototypes of what can be done. So this is exciting. And what Gareth is doing may be a model for elsewhere. We're going to hear from about another model and kind of where the value is in Africa. I think we've got a quick video from Johnny Mahlangu, who's going to talk to us about what it is like in terms of the possibilities for this kind of network in African services, how it's going to help serve their frontline service providers, but also the patients.
What can we learn from collaborations in the African region? I've learned over the years that there are many dynamic healthcare providers and patients living and working in Africa who are committed to elevating the level of care and delivery in our continent. We've seen this through a number of programs, through the twinning programs of the WFH, through seminars of the ISTH, and the American Society of Hematology. And of course, we were particularly fortunate in our center to be able to train a fairly large number of fellows, over 30 in the last decade. And training such fellows actually does not need very high level of resources. Twinning programs and the training programs that we have will certainly make a huge difference as being part of the networking. The second question that perhaps would be relevant is how do we envisage frontline services in South Africa and other countries in the region benefiting from the connectedness of the global network? My impression is that there are actually many benefits that the region could get. I mean, to start with, the network will allow us to build capacity in the region. This is now capacity for advocacy, capacity for diagnostics, capacity for a whole host of other events that we may plan. The networking will also allow us to share experiences in diseases that are actually common in our area, diseases such as sickle cell, etc., etc. And the third benefit would be sharing the treatment protocols and the standard operating procedures that we use for the treatment of these diseases. So how do we see the global network facilitating access to universal healthcare in Africa? My impression is that, in fact, rare diseases are unique in the sense that they are sometimes put in the back burner of most health systems, low down the list of priorities. And it is important that when we are tackling rare diseases, we keep in mind two principles. One, the intention is really not to demonstrate the burden of the disease. The intention should ideally be to demonstrate the outcomes following the intervention. And that to me is probably the most important principle that one should follow. And of course, one should take into account the available resources and all of the other factors. And then finally, in my view, what do I hope to achieve with the global network in our community and in our hospital? In short, I'm hoping that the global network in rare diseases will allow us to make diagnosis, to give better treatment for the patients with rare diseases, and to see better outcomes in many of these diseases. That is all I wanted to share with you, and thank you very much, and I wish you well in your deliberations.
So listening to what you heard there from Johnny, how does that relate to what you're doing in terms of building a network in the Philippines? And I also know that you're also been very much networked. You're doing not only a newborn screening, but also with clinical services.
So because of the geography, I have no choice but to do the network within the Philippines. So there are only 15 geneticists. So early on, before COVID, we had to come up with a system wherein we connect with every patient who's positive. So we came up with 15 clinics wherein every patient who's been positive is actually referred to this patient for free. Service is free because it's covered by government. But the beauty about this is that my commitment, our commitment to government, to the Ministry of Health, is that every clinic for newborn screening is a clinic for rare diseases and birth defects. So I'm telling them that if you support rare diseases, you're not really doing another investment. You're building an infrastructure and they're buying that. So, and I'm thankful that they have just started another roadmap. Now, the network that I have is not only for the Philippines, because the Asia Pacific Society for Human Genetics for the past, maybe 20 years now, have come together. Actually, it's a team of geneticists who have been sharing. So I think this sharing is really inside all of us. And in Asia, we just had to do it because we're so few in Asia that we had to start talking to each other. So what we're doing is really going to the next level. It's going to make life a lot easier for the Asia Pacific and the Southeast Asian region. I'm looking forward to working with this group. Thank you.
See that you're not so brilliant, Matt. You've got all the work that's already been done for you. What you need to do is to be able to clone it, to be able to share it, and then be able to brief. No, it's been amazing in terms of getting some of these experience, right, to service the models. So I think it comes back to a bit of what Johnny was saying, and a bit certainly in terms of what you were saying, Carmen, and that is, how can this network then help to facilitate the kinds of, developing a platform, sort of a global platform, where we can actually get different systems and different experts to actually network with each other. Matt wrote in here something about a speed dating platform. I refuse to address a question to Gareth and Salman about speed dating. So we're not gonna, we're not gonna ask him that question, but we do want to ask him the question about how could this kind of a global network, right, actually help in terms of getting experts across very, very geographically distant region and maybe different levels in terms of services and expertise. Is this going to be something that you're going to be able to use? And how does that also address, I think, a question that I think certainly Luis brought strongly, and that is the issues around diversity, equity, and inclusion.
Well, I'm really looking forward to going home and telling my wife that I flew across the world to speed date. But in all seriousness, one of the greatest challenges that this network will help us address, this global network, is how do we match expertise around individuals' patients' needs, around the clinical question that child, adult, and family are bringing to us. How do we in real time aggregate that? And so I think, you know, the social dating metaphor, if you like, is you know, how do we match that? How do we do that in real time? How do we match up the existing, you know, the expertise that individual clinicians and experts have, and how do we aggregate that in sort of real time? So I think there's a real opportunity about doing that. I think that's part of the digital health piece, and then will be a number of aspects of the digital health piece that'll be critically enabling, and I think this is a key one. That same mechanism also facilitates a key community need. We're in the middle right now. We're implementing our comprehensive centre for rare care back home at our children's hospital. And when we met with our community reference group for our regular meetings, one of the things that repetitively came up was we want second opinions. We want a way to facilitate that, and it would actually like sometimes, not always, our first doctor involved in the second opinion. And so that same matching process can be used to facilitate that patient need around gathering opinions and second opinions. And it's a way to get scale, because one of the real challenges for clinicians seeing someone with rare disease is identifying who is the experts and who are the real experts. Because there's one thing to have 300 publications after your name, that might denote you as being the real expert, but there are other ways that denote you as being an expert in terms of the good quality clinical care you provide. So how do we create that mechanism?
I think that's a really important point in terms of the clinical care, right? There's so many experts, and I think we heard that earlier today as well, is that let's not forget, there's not just the clinicians and not just the nurses, but there's other allied health professionals. They're all part of that comprehensive care team. And how do you actually make sure that you can bring them all in and maybe even share expertise around those other different levels in terms of, you and I talk a lot about mental health and social well-being there.
Can I just add one thing? I think, and again, it's where a community is leading the way. And if I make a parallel with an Indigenous health initiative, so in our home state, the primary care for Aboriginal Australians is large part provided by Aboriginal healthcare organisations that provide the primary care. And so because of the needs of that community to access care wherever they live, they came up with a solution. They designed the solution, and it was a digital solution using geospatial technology and aggregating data across different health data sets to actually organise care closer to home. So we've seen again another domain in the Indigenous community or a high needs community living in a remote area have created a solution. It's a digital solution that unlocks a human network, and I think that what the global network will allow is the expansion of these and application of these sorts of mechanisms.
And you certainly have been a pioneer in that area. I mean, what you've been able to do in terms of including those marginalized Indigenous and even the remote Indigenous community. I mean, I look at Jennifer here, a fellow Canadian as well, puts us to shame in terms of what we're doing in Canada. We have not done that same level, but this is an opportunity really to borrow from those models. So let me ask you, Salman, based on what you're hearing here, you've done an amazing job of bootstrapping operation in order to provide sort of an expert network, obviously out of your own need, but going way beyond that in terms of other families. But I also understand that you are doing work with beyond your own, disease area, looking at how you can actually expand that kind of expert networking. Is this something that you can see building into this kind of clinical global network? How would you take advantage of it? How might you actually inform it in terms of what else needs to be in place? And not from a structured, a clinical environment, but one in which is very much grounded in persons and patients, and also with the clinical experts.
No, absolutely. So I think from the outcome perspective, so for me, there are, let's say, two dimensions. One is that you are actually solving a real case issue, but you are solving in a way that you are training other people so that in future they will solve themselves, right? Because then you have a multiplier, and then you are able to, solve a bigger question in future. So absolutely, when I see that, this kind of this concept of global network, how this can help, and how, when I said that we did a proof of concept, and I want to kind of elaborate on that, it's that there has to be different dimension as well. Like, we don't need to look for a gold standard answer, but more like an operational answer or a fit for purpose, which by that mean is that the both communities in a way, or if you are having a regional networks or across regions, Europe and Asia, they need to work together. Experts needs to work together. There should not be a concept that the experts from Europe are going to tell you how to treat it. You will get a wrong answer, right? So you both need to find an answer which is fit for the purpose. And also the debate on that you were bringing, who is expert or not. Actually, we tried a different concept. We are asking young people, what do you think about that case as well? So that you have a senior expert known, but also the young person. And there is a very nice way of collaboration and then interaction, and then how you store all that for the future learning. That's ultimately helping a lot. And then how you use the technology so that it doesn't stay in one country, even in one region, but across region. And to your point, to global network. So that will all feed into that. And I will just close. For me, the key word is integration. Things exist everywhere. It's how you connect them, but not to create, like the work with Joergensen, for example. So their platform, how we can use and then feed it for our purpose. So I think that's the key, how you integrate things together in the end.
We're running out of time, and I realize I've not really left enough time for questions from the audience and others, but I do want to ask this question because I think it really speaks to a different level, and that's back to Per and Lisa. Quite frankly, we're talking about huge needs from the grounds up, and why there might be a sense in terms of experts and clinicians and even the patient community coming and say, yes, we want to be a part of this because it's going to help us. What do you do when you've got already centers of excellence? European reference networks really tried to bring together centers that themselves were saying, we're already experts. What do you want us to do? And also asking some of them to become hubs within a bigger spoke area, hubs and then other spokes. And the same thing I'm going to ask Lisa, you can answer in turn. Your clinical centers of excellence are not just, kind of community networks. They are major children's hospital pediatric centers. And we're saying, we want you to network together. We want you to work together. How do you talk about these people who can set aside their egos to say, sure, there's a value to us in terms of collaboration? So I'll start with Per, because you've had the longer experience. Then maybe Lisa, you can talk about how you sweet talk these clinical directors into this.
Well, I'll try to do it very briefly because we're short of time. But I think everybody can see the good aspect of more experts. And global experts are better than European experts, which are better than national experts, and so on. But we need something. And I think today is a very important day, as you started out, Joanne. And actually, I think that perhaps the most important supporter for making a national, international network is RDI, because even though we might be very, very keen in the individual systems, we're not able to do it ourselves. We need some organization to have the bigger overview, to provide the infrastructure, and the idea of doing it, for instance, with RDI and WHO, I think is brilliant.
Very much. Lisa?
So it's interesting. There's always a few who don't understand the value that's in it for them. I think that's pretty standard and typical. But in the US, I have to say, we didn't have to do a lot of convincing. And I think part of that is that we had support from Dr. Marshall Summer, who really had been out there socializing the idea for several years to try to get people on board with this idea of forming a network and bringing everyone together. And so by the time we were ready to roll out the criteria process, everyone was already on board and signed up to help us do it. So I think that really helped. I think the other thing too, which I don't know if it's unique to the US, but in the US, you've got centers of excellence for cystic fibrosis, for muscular dystrophy, for pulmonary hypertension. And what we've seen is that, yes, an individual center can recognize themselves and say, we are a center of excellence for this disease. Does it count as much if the patient community doesn't also recognize them as a center of excellence? Not in some cases. And so what we really saw too was this need to really have both parties coming together to say, this is how we define excellence together, and that we are going to validate your designation as a center of excellence in rare diseases by having the patient community stand behind you and support you.